online or use it for any other purposes. If you have any problem being part of a recorded event, we invite you to leave now. When you're remaining with us this evening, implies your consent to participate in this type program. The program this evening provides 1 hour of Category 1 Physician AMA CME credit and 1 hour of Virginia Nurses Association CE credit. Sovah Health CME program is accredited by the Southern States CME Collaborative, of which the Medical Society of Virginia is a member. And we are accredited through the Virginia Nurses Association to provide nursing center CE credit for these programs. The program is developed with a desirable physician attribute to provide patient-centered care and to promote and utilize evidence-based medicine practices. Dr. Gettler, our speaker this evening, myself, and members of the Sovah Health CME Committee have nothing to disclose as far as commercial relationships. The program this evening, as is the case of the majority of our programs, is supported by the Ralph Landis Medical Education Fund. There is no commercial support to the program this evening. The fund that Dr. Landis created at the time of his retirement is utilized to promote and support speakers for medical education for all types of healthcare professionals in this area. This fund resides at the Danville Community College Educational Foundation and is managed by a volunteer committee there. You will receive this evening by email, or we'll show you another way you can access it, a program evaluation form. We ask everyone to take a few minutes to complete it. On that form, you will be asked to re-enter your name as well as your email address, and that's so we can send you a CME certificate, which comes from that name. So please put your full name on the evaluation name request. Please don't give us any nicknames or shortened names, because that's what will be on your CME certificate. If you're watching and viewing this with someone else and only one of you is registered for the program, please let myself or Mary Ken or Van Holt know so that we can be sure that you do obtain credit. Evaluation forms are not required for physicians necessarily to get credit, though we hope you'll do that. On the other hand, for nurses to receive CE credit, it is required that you submit an evaluation form. We added a few months ago a new option where you can, at the end of the program, in the chat box, there will be a QR code that you can snap a picture of and follow that link to get to the evaluation form if you prefer that type of accessing evaluations. For our many residents who are on the call, Sovah Health residents, please know that your residency coordinator, that's Derek Johnson and Leslie and Ms. Galvez, Lori Galvez, they track your CME participation, so you do not have to keep up with CME certificates. Otherwise, the system will email to you a CME certificate after the program and the eval form comes back. I like to, each time we do a program, specifically thank Mary Kent and Van Holt for their help in our providing these programs for you. Without them, we could not do this. And I greatly appreciate all the many things that Mary and Van do to maintain the accreditation and to make all this magic happen. I know Dr. Gettler will encourage questions and comments regarding things she talks about. We urge you to do that. It makes the whole evening a lot more warm and fuzzy. You also can send in your questions through the chat box. Mary will monitor that, or you can simply just speak up. If you do speak up, we ask that you ask your question and then mute your phone when she responds, simply to eliminate the feedback that the system gets. You are more than welcome to do more than one question or comment. We urge and welcome all such. So no problem doing that. Just please mute once you finish speaking so that we don't have so much feedback through the system. I want to highlight for you a few of the upcoming programs over the next few weeks. Next week, this will be our 4th Thursday night in a row in February. February's been a big CME month. We're going to have Dr. Kimberly Beavers, a gastroenterologist here at Sovah Health, talk with you about risk factors and screening for colon cancer. And she'll be addressing the questions of does everyone need to have colonoscopy versus some of the other systems that are available to screen for early colon cancer. March 6th, we'll have the last of this series of cardiology programs where Stephen Green and Dr. Fadim will be talking about the heart failure update. Dr. Green will go through the American Heart Guidelines for optimal heart failure management. That now has become quite a undertaking in the sense that there are now multiple classes of drugs that can benefit cardiac function in heart failure, and they're additive. And it's something you need to know about, as well as pacing these patients. And then Dr. Fadim has a unique program of remote monitoring of heart failure status once patients go home, so they can determine volume status remotely on the phones, as it were, and be able to monitor them and reduce readmissions to hospital. And then March 13th, we'll have our first series of programs this year on equity and inclusion with Dr. Tobe, who leads the Women's Heart Health and Cardio Obstetrics Clinic at Cone Healthcare Systems in Greensboro. This is a very unique position to have a duly trained cardiologist, OBGYN doc, managing maternal health. And so we hope you'll be able to be on that call with us. That leads us to this evening, and I'm delighted to introduce to you Dr. Aaron Gettler, a member of the Infectious Disease Division at Duke University Medical Center in Durham, and also a member of the Duke Antibiotic Stewardship Program, or what we know as DASON, of which Sovah Health has participated for many years. It's a really, we really want to compliment Dr. Gettler on being able to be with us this evening. She is from the greater Kansas City area, and despite the Super Bowl, she has rallied to enthusiastically talk to us tonight about UTI Stewardship. So kudos to you, Dr. Gettler, for that. We're just so sorry that Kelsey and all his good friends couldn't make it happen. But that being said, Dr. Gettler is a really, I don't know, if you want to know about an academic star, this lady, this physician is that. She completed her bachelor's in biology with a parallel specialty in gerontology at Kansas State University, where she graduated summa cum laude. And she was elected or chosen as the most promising student in the Department of Biology during her years there. She then followed with her MD degree from Georgetown University in Washington, D.C., again, magna cum laude, where she was chosen for the Medical School Honor Society, Alpha Omega Alpha, nicknamed AOA. If you're not into academic medicine, you may not be familiar with that, but that is a huge, huge honor if you're in the medical school world. She then went to Vanderbilt in Nashville and completed her IM residencies, and that was followed by fellowships both at Vanderbilt and then finally at Duke in infectious disease, infection prevention, antimicrobial stewardship, and, if you will, infectious disease epidemiology. While a fellow at Vanderbilt, she was selected among all of the medicine specialty fellows as the Outstanding Medicine Fellow. She has been a reviewer for numerous high-impact national journals, usually in infectious disease. She has numerous publications, including a book chapter, and we are just delighted to have her talk with us tonight. So, Dr. Gettler, if you bring your slides up, mine will fall off, and it's all yours. Thank you so much.
Well, thank you so much for that really generous, probably overly generous introduction. Your kind words were appreciated, especially to ease my pain I'm still feeling, I think, from the Chiefs' loss. But it's really a pleasure to be here with you guys, and seeing your lineup of upcoming speakers over the next few weeks. I'd really say it's an honor. You have quite a lineup of people, and so I hope to do this justice for the infectious diseases world. Today we're going to be talking about urinary tract infections and specifically focusing on some diagnostic stewardship opportunities and treatment strategies.
Dr. Gettler,
Yeah.
your slide got small. It started out,
got small.
and then it just got small.
Let's see.
Okay. And then, yeah. Okay, looks great.
So if I try to bring up that, you're seeing the presenter view.
Exactly. That's when it gets small.
Looks like you're in presenter mode where you can see the next slide.
So when you're in the other mode, can you just advance it? When
I'll bring it up again, share again.
I'm sorry.
no, you're totally fine.
The problem might be if I lose my.
Okay. And then when you go into presenter mode, when you go to the screen, okay, click on that. Okay, and then when you advance it, is that when it's getting small?
Getting
Does it
small
look-
when I try to put it in presenter mode.
It looks good now, but you can't, then it gets small. So
Yeah.
Maybe you just need to hit that little window at the top.
What I'll do, maybe,
what is causing it to get small? Like when
when I put it in presenter view, I even tested this earlier, so that I can see my notes, then you can't see the full slide.
oh, I see. Okay.
Usually if you hit share and then below that, click on the little window icon, then you can pick the one you want and it'll go to full screen usually.
And if you want to, I can bring your slides up and advance them for you if you want to be able to see yours and see your notes.
Yeah,
Happy to do that. Oh, look, we can see you. Okay, and that looks good. Can you see your notes?
That's the problem. Okay, what if Mary, I've changed my slides because there's an update, there's a treatment recommendations update that happened today, late breaking news. And so you don't have my most recent slides. If I send them to you really quick, do you think that would work?
Sure.
Okay, I'm sorry.
That's okay.
Everybody else just talk among yourselves just a few moments.
Yeah, sorry about that.
We did a test connection just a couple of days ago and everything worked perfectly. So maybe the wind's blowing a different way from Durham. I don't know.
It's a cold Arctic wind, so just have to be ready. That's all.
Well, that's what happens when the wind changes. Teams kind of leans over sometimes. So.
Okay, Mary, I just sent it to you. Sorry about that. I even did a test run earlier, and it worked earlier today too. So I'm sorry if I'm doing something different this time.
Yeah, it's totally fine. It's happened to all of us.
Stuff happens.
I'm still waiting for them, Dr. Gettler. I'm sure they're on their way.
They're hung up in Hillsborough at the traffic light.
So while I'm waiting for them, if you want to keep playing around with it and see if you can figure it out, I can't see. Maybe you're already doing that. Sorry.
Trying to make sure it's sending to you. I'm just checking. It's sending.
Okay.
Should be there.
All right. Watch pot's not boiling yet.
Mary, do you have them yet? Yeah, there you go.
Yeah, I think that.
Great. Whoever's in,
Okay,
it looks great.
you can see it now.
Yes, ma'am.
Yes.
Okay, let's roll. Sorry, y'all.
No, totally right.
So as was mentioned, I have no conflicts of interest. So here's our game plan for this evening. We're first going to spend a chunk of time talking about diagnosis. So diagnostic stewardship, urinalysis, what it is and what it isn't, indications for urine cultures, and then a little bit about how to manage urinary catheters and some diagnostic stewardship opportunities around UAs and urine cultures in those patients. And then we'll shift gears and spend a little bit of time about treatment. And there's actually been a really exciting update as of yesterday. The IDSA published an updated treatment guidance for complicated UTIs. And so we'll highlight a little bit of the difference to think about a framework of simple cystitis versus pyelonephritis or complicated UTI and how that can inform treatment. Spend a little bit of time talking about multi-drug resistant organisms, specifically ESBL gram-negatives. And then I'll highlight a little bit of your local antibiogram and some treatment guidance resources that you have for your institution. All right, so stewardship, it can sometimes get a bit of a bad rap. I think people think it's synonymous with limiting testing or antibiotic use. If you actually look up stewardship in Webster's dictionary, what it defines is it's the conducting, supervising, or managing of something, especially the careful and responsible management of something entrusted to one's care. So really, stewardship isn't just about antibiotics or even infectious diseases related tests. And it isn't just the work of pharmacists or ID physicians, it's really every provider's responsibility. And so really, if you think about it at its simplest and at its core, being a steward really goes hand in hand with being a thoughtful and good provider. But we're going to focus on diagnostic stewardship. And so that specifically refers to the process of modifying the ordering, the performing, the reporting of diagnostic tests to improve the diagnosis of and treatment of infections and other conditions. So diagnostic stewardship can be described as interventions that prioritize the right test for the right patient and for it to prompt then the right action. All right, so an awareness and understanding of pretest probability of infection is then essential for designing diagnostic stewardship interventions that improve the usefulness of tests. Pretest probability, I'm sure everyone's aware of, just kind of a quick little segment about what that is. It's when we ask, what is the chance that my patient has disease X, estimated before the test result is ever known. It's based on the probability of the suspected disease in that person given their symptoms. Many diagnostic stewardship interventions function by increasing test use in high-value settings where there's a higher probability of disease. So as an example, we think about drawing blood cultures in a patient where we're concerned that they have infective endocarditis. They also discourage or block testing in low-value settings where there is a low probability of disease and a greater potential for false positive results. So taking kind of the same sort of example, cystitis, pretty low risk to have concomitant bacteremia, so blood cultures in that instance would not be indicated. So diagnostic stewardship interventions aim to improve patient care and avoid harms, optimize antibiotic use, and improve healthcare efficiency and reduce cost. I really like this figure. I think it zooms out and gives the relationship between diagnostic and antimicrobial stewardship, as well as the roles that patients and healthcare providers and the laboratory play. We all have a role in this greater stewardship mission. So we said that diagnostic stewardship is really about choosing the right test for the right patient and at the right time. And this is important because inappropriate testing has consequences. The most common type of inappropriate testing is overtesting. And that can lead to diagnostic errors in the form of overdiagnosis, unnecessary antimicrobial treatment, and excess costs. And as we know, the potential sequelae of inappropriate antibiotics are pretty vast and include adverse drug events, development of multi-drug resistant organisms, disruption of the gut microbiome, C. diff, and that's just to name a few. I think that this chart taken from this publication there from JAMA Network Open is just really enlightening to kind of think about how some of those inappropriate tests that are listed on the left side of the column and the potential consequences that can result from those. We often think about overdiagnosis, but it's also important to recognize that there's misdiagnoses and anchoring that can happen if we order tests inappropriately. Inappropriate testing can contribute to misdiagnosis, like I said, and in turn that can create delays in treatment for patients or missing the true diagnosis. This table is taken from a commentary in JAMA, and it highlights a couple diagnostic stewardship interventions and their impact on diagnostic error in patient care. To focus there specifically on UTI, there it's in the red box, limiting the processing of urine cultures to only patients who had pyuria present, decreased the misdiagnosis of UTI, and reduced unnecessary antibiotic prescribing. So we're going to come back to that a little bit later in the discussion where we can use pyuria as a screen to really improve our use of urine cultures. All right, so now that we've kind of had the framework about stewardship, let's talk a little bit about UTI diagnosis. We're going to start with a case. And so this is the patient, 65-year-old woman. This is a true case. Has a history of AFib, diabetes. She comes into acute care walk-in clinic with fatigue, shortness of breath, increased leg swelling. And, you know, when you do a review of systems, she does acknowledge she's been having some intermittent burning with urination. She has a little bit of a difficult historian to kind of pin down how much it's happening, but it seems like it's not really been prevalent in the last week or so. But you get a UA, and you can see here the results highlighted in yellow that are most notable. You can see there at the bottom, she really doesn't have too many white blood cells, just 5. But the bacteria that's shown there, 5 to 50, gets your attention. Based off all that data, does she have a UTI? The myth number 1 is that we can diagnose a UTI just from a UA. This logic, I think, could really be extended to a urine culture, not just a UA. I hear that frequently from patients where they'll say, well, I had a urinary tract infection. And when you really try to home in on what it is that they're rooting that belief on, it comes down to a urinalysis or urine culture result taken in isolation. But interpretation of test results really relies on the clinical scenario and whether symptoms are present that are consistent with a UTI. There are more than 15 elements to a UA when you also get the microscopic exam. And so I think it might be helpful to review just a few of those briefly to understand just how good the tools are that we're using to try to support our diagnosis of UTI. So let's deconstruct the UA just a little bit. The components of urinalysis are listed here kind of in buckets. First is the gross examination. You'll sometimes hear patients report a suspicion for UTI based on the color, the odor, the clarity of the urine. Yet these are pretty non-specific and can be affected by a myriad of things like medications, their hydration status, and even food consumed can alter those parameters. Next, we think about the chemical examination. Leukocyte esterase and nitrates have been traditionally used to evaluate for UTI. But what I'll elaborate on in the coming slides are just how good are those tests really in informing whether UTI is present. For leukocyte esterase, that just signals inflammation. So that can be from infection, from catheterization or other instrumentation like a cystoscopy, and even sexually transmitted infections. So it has a good negative predictive value for UTI. That's when it isn't there, a UTI is very unlikely. But it lacks specificity because of those other causes, like I've mentioned, other than infection that can cause it to be detectable. Nitrite can indicate the presence of gram-negative bacteria. And I mention that because not all urinary pathogens are gram-negative, so not all of them will produce nitrite. You know, think about Enterococcus, that wouldn't produce a nitrite. That test would be negative, even if someone has an Enterococcus UTI. So you can get false negatives. You can also get false positives. Specimen contamination or how it's handled, exposure to air can make that falsely positive. So it's truthfully not a very helpful test, even though we often kind of lump it into part of the chemical examination that might be important to look at. Lastly, the microscopic examination. Similar to leukocyte esterase, the presence of white blood cells, which is what the pyuria detects, just indicates inflammation, and that can be from any cause. The degree of pyuria, number of white blood cells per high power field, doesn't reliably correlate to bacteriuria or infection. So that case that we just discussed where she had quite a few, where she didn't have many white blood cells in there, you might think, oh, low likelihood of infection. I think that logic, seems natural. And so you might think, well, if there's a lot of white blood cells, 50, the next time you check, it's 100, more likely to be infected because there's 100. And actually studies have proven that that type of quantification doesn't correlate with a true UTI. So like leukocyte esterase, pyuria 2 has good negative predictive value. If there's low white blood cells, unlikely that the patient has a UTI, but it doesn't have a good positive predictive value because of its limited specificity. The case that I highlighted, she had a lot of bacteria there. Gosh, it seems worrisome, but what I want to share are some significant limitations about the bacteria detection, the microorganism detection that happens on these urinalyses. The microscopic exam, it's really not actually through microscopy most of the time, so it's a bit of a misnomer. Most parts of that test in most labs, it's an automated flow cytometry or an image analysis with or without actual manual microscopy. And so it can't detect true bacteria presence very well. And even if bacteria are there, it certainly can't detect or distinguish the difference between pathogens and non-pathogens or viable bacteria from non-viable organisms. So the detection of bacteria on the microscopic examination may be associated with positive urine cultures, but it can't differentiate between asymptomatic bacteriuria, contamination, or a UTI. These data shown on this slide are from a retrospective cohort study. The authors evaluated the performance of relevant UA parameters as potential predictors of significant bacteriuria, which they defined as a urine culture with one or more urinary pathogens that grew at least 100,000 colony forming units. And here's a subset of the data where they looked at the performance of bacteriuria or the presence of bacteria on the microscopy in diagnosing a UTI. The table there, I think what I've tried to highlight is the sensitivity, specificity, positive predictive value, and negative predictive value by cutoffs. You can see from the table that bacteria in urinalysis had low specificity and high sensitivity, but sensitivity decreased as you increase that threshold, increase the degree of bacteria present. That had a pretty poor positive predictive value. In other words, what's the likelihood that a patient with a positive test truly has the disease? It's pretty much a coin flip when you look at those numbers. Typically, when we think of infection, we hone in on the nitrates, leukocyte esterase, or pyuria. So let's discuss those other parameters just a bit further. First, for nitrates, when we look at that same subset of data, we see that nitrate had low sensitivity but high specificity. When we look at the positive predictive value, we're still seeing it's pretty low in the 70s, not great for this type of test. The other issue with nitrite is that it can't distinguish between infection and colonization either. I did mention a little bit of the issue with nitrites for detecting all urinary pathogens. It's things like Staphylococcus, Pseudomonas, Group E strep, Enterococcus faecalis, fungi. Not all of those produce nitrate reductase, and so this nitrite test may not be positive if there is even a true infection from those organisms. So for these reasons, a positive nitrite test is truthfully not that useful for the diagnosis of UTI. All right, so we said presence of bacteria on urinalysis, not so helpful. Presence of nitrite may or may not be helpful. What about pyuria? So there's varying degrees of pyuria. 5 or more white blood cells per high power field, or 10 white blood cells per high power field tend to be the cutoffs that are used in most studies. In the study I previously referenced, the authors used 5 or more white blood cells to define low-level pyuria, and that retained pretty high sensitivity. But like we already discussed, pyuria has low specificity as there's many other causes of pyuria aside from a urinary tract infection, and I've listed just some of them on the slide here. I think that this is just kind of humbling to think about how many of these could be altering those parameters on the urinalysis. Systemic illness such as diabetes or being postmenopausal can even cause pyuria. I was surprised to see that PPIs, something so simple, a lot of our patients take over the counter, can also be a cause for pyuria. So sensitive, but not specific. This table, I hope will look familiar to some in the audience, maybe some familiar names on that byline as well. This was a cohort study of nearly 4,000 patients, including some from Sovah Health and some authors from Sovah, who these were patients who received urine tests for a suspicion for UTI. They looked at all UA parameters alone or in combination, and all of them really had pretty poor positive predictive value for the diagnosis of UTI. So I've talked a lot about limitations of a UA. So what can a UA do? It really can rule out a UTI if there's no inflammation. If there's no pyuria, no leukocyte esterase, there's a very low likelihood the patient has a UTI. I will acknowledge a caveat here, and that's in the case of neutropenia. If a patient doesn't have many circulating white blood cells in their bloodstream, pretty unlikely to mount a good response or an inflammatory response in the urinary tract. So that is a patient population where, pyuria might have to be interpreted kind of with caution, have to have a higher index of suspicion for UTI in that patient population. But for most patients, the pyuria and the leukocyte esterase, if they're absent, helpful to kind of rule out UTI in your differential. If they're present, because of the reasons we've looked through, they're not specific. It doesn't necessarily mean the patient has a UTI. You really need to have that clinical correlation. So that brings us to this. How do we really diagnose a UTI? The most important thing is selecting the right patient for that right test. Setting up the situation in which the pretest probability permits the best use of a urinalysis and urine culture. So the most important thing is really to start with symptoms. Symptoms of dysuria, suprapubic tenderness, flank pain, CVA tenderness, or certainly if someone's in septic shock. So symptoms, and then in that right patient demographic, we then think about the right test then. So if you have the right clinical context, then you can go on to look for inflammation on a UA, both by leukocyte esterase or that pyuria greater than 10. If there's a true UTI, there should be inflammation in the bladder evidenced by either of those parameters. And then the last element is a positive culture, which should confirm more than 100,000 colony-forming units of a urinary pathogen. If it's lower growth than that, I think it really calls into question. It doesn't necessarily rule it out, but I would advise caution in assuming it's a true UTI. Usually we want that type of robust growth on a urine culture. So let's look at case number 2. 80-year-old woman has a history of diabetes and dementia, pretty advanced dementia, and she's admitted for decreased mobility, increased fatigue, and confusion. You look through her records and there's been a lot of urinalyses sent over the past several months, and you see that she's had pretty significant pyuria all along. Now, remember we learned that quantification doesn't necessarily correlate with degree of bacteriuria. So if she has 900 white blood cells, it doesn't necessarily mean she's more likely to have a UTI than when she had 447, but still pretty notable pyuria. We already learned that bacteria count on the urinalysis isn't really so helpful. We learned more from our patient that she's got a urinary catheter in place, and it's been in place for quite some time. So the big question is, does she have a UTI? We're going to use this case to highlight a couple points. So first is asymptomatic bacteriuria. Just how common is this? The short answer is very common, especially in older adults and those with indwelling catheters. ASB occurs in 3 to 20% of older adults that are living in the community, and up to 50% of older adults that reside in long-term care facilities. So urine isn't sterile. There's going to be white blood cells and bacteria in there. It's not like the blood where you would expect it to be sterile. And so urine cultures intrinsically have a pretty high false positive rate. When we then insert the catheter into the picture, bacteriuria becomes even more common. It's a common colonizer of the indwelling catheter, and most catheters are colonized at a rate of 3 to 7% per day. I think this schematic is helpful just to kind of think about that for some of these patients who have catheters in place for a pretty extended duration. You can see from this illustration adapted from this paper in infection control just how that happens. So if you're evaluating a patient who's had a catheter in place for a few weeks, I mean, they could be approaching 100% colonization of that urinary catheter. Culture it, there's going to be a bug or bugs there. Asymptomatic bacteriuria is often associated with pyuria as well. So in that same cohort of patients, those in long-term care, those with indwelling catheters, the presence of pyuria on a UA really isn't so helpful. So this patient was treated for UTI again, and really didn't have much clinical response. Somewhere in the course of her evaluation, this was a true case. She had a couple days of treatment for UTI before someone actually took her sock off and looked at her toe and found a much different reason for her to be altered and kind of present the way that she did. And so the harm really for this patient was that there was an anchoring bias. The test was done in the ED, and so the admitting physician saw that first and really kind of thought, well, that must be it. The team felt that they had a good explanation for her lethargy and stopped there. Luckily, someone eventually looked at her foot and found this and ultimately was able to redirect her care. So we talked a bit about misdiagnosis and anchoring bias as a consequence of inappropriate testing. But there are other harms too. UTI is often among the most frequently misdiagnosed infections associated with C. difficile infections. This figure displays antibiotic adjudications by indication among patients admitted to Duke University Hospital who developed healthcare-associated C. diff. And so you can see there, if you look at the UTI specifically, in orange are the cases in which antibiotics were inappropriately delivered. The patient didn't have a true UTI on retrospective review. We acknowledge that retrospective review has limitations, and so sometimes it's uncertain. That's the lighter blue color, and then the appropriate is the darker blue. Suspected UTI was the single most frequently mistreated syndrome amongst those shown there. So while folks want to order the UA and urine culture to have just in case or to be thorough, it's well-meaning, but the reality is that treating asymptomatic bacteriuria does not prevent infections and in fact can cause multiple other harms. Another learning point from this case is about the handling of indwelling urinary catheters. Catheter-associated bloodstream infections and urinary tract infections account for 1/4 of all healthcare-associated infections. And these are costly. Device-related infections are a significant cause of morbidity, healthcare costs, and antibiotic usage. Outside of ICUs, a significant portion of urinary catheters do not have an appropriate indication for use. So how good are we at knowing if our patient has a catheter? We have room for improvement. So in this study, physicians were given a list of patients on their service. For each patient, the provider was asked if the patient had an indwelling urinary catheter. Overall, providers were unaware of catheterization for nearly 30% of the observations. They also broke that down then by level of training, and probably not a big surprise to most of us that we get a little bit worse as we get further on in our training. Medical students were the best performers relative to interns, residents, and attendings. So we do a little better at being aware of a catheter when the indication for catheterization is appropriate. But perhaps not surprisingly, those rates worsen when there isn't an appropriate indication for the catheter. Similar to the estimate shown before, the catheter use was inappropriate for 31% of patients, and providers were unaware of the catheter use for 40% of the patients who were inappropriately catheterized. So finding ways to automate or be methodical about evaluating a patient's lines, tubes, drains, devices is important. So I challenge all of us, myself included, to be aware of and really evaluate the need of a catheter that's in place. While not a comprehensive list, indwelling catheters are appropriate, in cases of bladder outlet obstruction, neurogenic bladders, during or after prolonged procedures when there's been general or spinal anesthesia, and urinary diversion when patients are incontinent and we're trying to help heal open perineal or sacral wounds. But I'd also challenge us to think about alternatives. Maybe there's an external urinary device that would suffice, especially if we're just really interested in strict I's and O's. Would there be a way to get the indwelling catheter out? If a device is necessary, ensure we're caring for it and maintaining the device properly to minimize complications or device-related infections. If a patient has an indwelling catheter and has signs and symptoms concerning for a UTI, then there's some general best practices about how to collect a UA and urine culture in order to optimize your diagnostic yield and reduce the risk that you're just colonizing the stuff that's been living alongside that tube for the last several days or weeks. So the LifePoint policy for urine culture ordering and processing is congruent with the CDC recommendations, which say that urinary catheters that have been in place for 14 or more days should ideally be replaced before a urinalysis and urine culture sample are actually collected. If it's safe and feasible to exchange that catheter after doing so, the specimen should be obtained from the collection port, so not the bag. And so sometimes we have to provide a little bit of coaching to our nursing staff about best practices for how to do that. And it's done under sterile techniques. So hand hygiene, gloving is important. And the collection site should ideally be documented. So really capturing clean catch versus catheter access port for a urine specimen. Myth number 3, UTI is a major cause of confusion. I think we can probably all relate to the clinical scenario of an older adult like the one I presented, who presented with some delirium, was found to have either a positive urinalysis or a positive urine culture. In the absence of clear localizing genitourinary symptoms or other systemic signs of infection, the IDSA guidelines recommend careful observation off antibiotics and evaluating for alternative causes before proceeding to antibiotic treatment. I think this can be really hard. I certainly found it challenging when I was a hospitalist, and I still find it challenging as an ID physician. A patient's cognition may limit the ability to obtain a reliable history, but I think the takeaway message, in the absence of fever and in the absence of hemodynamic changes, we have time to investigate other causes of their delirium and really be thoughtful about whether that UA and urine culture are truly the process driving their delirium and confusion. These authors attempted to do a systematic review to look at potential linkages between confusion and UTI in older adult patients. There were over 1,700 original records that they identified, of which only 22 were included in the final analysis based off their inclusion criteria. The quality of these included studies were really varied and diverse. There were very frequent poor case definitions for UTI or confusion, and so there was ultimately a large variation in results and limiting the validity. They ultimately couldn't do any type of meta-analysis. And so there was a little bit of a limitation with what the goal was. So here's where our geriatricians came to the rescue. This study was performed on older adults with a positive delirium screen, a positive urinalysis, and who were admitted to the hospital. They sought to determine the rate of antibiotic treatment and the proportion of asymptomatic patients, asymptomatic other than the delirium, as well as examine the effect of antibiotic treatment on delirium resolution and adverse outcomes. The short takeaway is that treating the urine didn't help. Antibiotics were given to a shockingly high number. 86% of the patients were receiving antibiotics. The asymptomatic subgroup, that was the delirium without urinary symptoms or without fever, comprised 38% of the cohort, and they received antibiotics 68% of the time. There was no significant difference in delirium rate on day 7 between the antibiotic treated and the antibiotic non-treated groups, or in 30-day adverse outcomes. So despite a staggering high rate of antibiotic use among this group, there was no change in the outcomes of interest. So after reviewing a couple cases, breaking down the different components of the urinalysis and what a UA can and cannot do, We have the evidence to debunk some of the common myths or scenarios that are often misattributed to a UTI. Really, it comes down to relying on the presence of localizing symptoms to guide testing. I certainly hear a lot of these things a lot. And so I think I'm hopeful that now you'll be empowered to kind of debunk some of the things like changing and urine characteristics, smell, color, clarity, or sediment being an indicator of a UTI. A dirty UA, we've already learned kind of the pros and cons and limitations of a UA. A positive UA, urine culture without urinary tract symptoms, that space is not sterile. I certainly used to hear this a lot when I was a hospitalist. I still do a little bit that families, it's well-intentioned. They, are caring for their loved one and are worried that this is how she gets when she has a UTI. And again, remember that anchoring bias and misdiagnosis case. Occasionally comes up about screening urinalyses or urine cultures in patients who are asymptomatic. I see this mostly in preoperative patients, preoperative for procedures outside of a urologic one. It's appropriate, we'll get to in a minute if someone's going to have a urologic instrumentation, but we actually see this sometimes from our surgeons for other surgical procedures. So IDSA says that you should really not screen patients for asymptomatic bacteriuria in most cases, including the patient populations shown here. So it's probably easier to remember who to screen instead of those who not to screen. So it's really quite few that we should be thinking about screening for asymptomatic bacteriuria, really 2, maybe 3 special circumstances where we do that. Pregnancy, invasive urologic procedures, and perhaps in the first month after renal transplantation. What I will say is for the first and third bullet, there's actually some evolving evidence that suggests that maybe that's not even best practice, but for now, all of these are still included in the guidelines. So how do we use our knowledge and expertise then to actually improve our practice? How do we translate what we just talked about into actually improving the care for our patients? Education about best practices is important, but it's really a pretty weak intervention in that there will be provider turnover, practice drift, and the need for message reinforcement. So leveraging the EMR is a great way to build in clinical decision support at the time that it's needed by the ordering provider. Things like nudges or best practice advisories or hard stops can be used. I want to spend a couple minutes talking about a UA with reflex to culture. Let's walk through this algorithm a little bit. You have a patient that's not pregnant, not awaiting the urologic procedure, and is not immunosuppressed. And you can follow that down to the bottom. UA and reflex urine culture order. The UAs run first. So if you have 10 or more WBCs, that's what people often refer to as the pyuria screen, and there's less than 1+ or less than 10 squames, so it indicates that it's a clean catch, it's not a contaminated specimen, then that specimen should be processed for a urine culture. If it doesn't meet those parameters, either the patient doesn't have a UTI, they didn't have a significant amount of pyuria, or it's contaminated, there's a lot of squames in there, we're going to have to try to recollect a better specimen. As we have seen, patients with asymptomatic bacteriuria or indwelling catheters can have pyuria in the absence of a clinical UTI. So these types of patients will meet the pyuria threshold to have a urine culture run. So this type of stewardship intervention is great, but it's not a substitute for the important clinical evaluation to assess for signs and symptoms consistent with the UTI that needs to happen upstream of ordering the test. So again, just to highlight, this is a great way to at least reduce the number of UAs that are going to an inappropriate culture, but there will still be patient populations that would get through that pyuria screen because they inherently have pyuria. And so it really doesn't negate the fact that you have to be an astute clinician and really still thinking about whether the signs and symptoms are there. This study implemented a conditional urine culture ordering when strict UA criteria were met. They also used a threshold of white blood cell count of 10 or more. Shown in this figure is the rate of urine cultures before and after the intervention. The number of urine cultures decreased in the implementation sites. It's in the lower dashed line, but a similar trend was not seen to the control sites. That's like the higher solid line. The safety outcome was the rate of gram-negative bloodstream infections per 1,000 patient days, and this did not differ between the control and intervention sites. So conditional urine cultures or pyuria screen with reflex culture, kind of different terminology for the same principle, can be a safe and effective way to reduce inappropriate ordering of urine cultures. We talked a little bit about the appropriateness of urinary catheters and making intentional efforts to reduce the catheter, to remove the catheters as quickly as possible, and as safety permits. It's really for a couple of reasons, but catheter replacement is certainly a huge risk for catheter-associated UTIs. In this multi-center study in the Netherlands, investigators employed several de-implementation strategies to improve appropriate utilization of urinary catheters. Their de-implementation strategy was pretty time intensive. It was educational outreach to providers. They did some audit and feedback reports, and they really leveraged the EMR to help their efforts be a little bit more sustainable. There was a nurse-driven protocol to empower nurses to remove catheters that did not have an appropriate indication. And this is really so critical. Like most QI work, they really identified their stakeholders that relied really heavily on local nursing and physician champions to keep this effort afloat. And shown here are the fruits of their labor. It's an interrupted time series analysis before and after the de-implementation. It shows the percentage of patients with an inappropriate indication for catheter. And so you can see that declined significantly after the intervention. All right, let's shift a little bit towards UTI treatment. There's been a lot of various definitions and frameworks used both clinically and in studies to define uncomplicated versus complicated UTI. There's been a move really towards defining these entities based off the level of suspected involvement or based off of the syndrome, rather than automatically considering patients with underlying urologic abnormalities, immunocompromise, or poorly controlled diabetes as complicated if they have no concerning symptoms for upper tract or systemic infection. So in this framework, the term complicated UTI refers to an acute UTI with features that really suggest infection has extended beyond the bladder. Fever, rigors, flank pain or CVA tenderness, pelvic or perineal pain in men, because that can sometimes be a suggestion of prostatitis, or certainly if they had other systemic signs and symptoms. By this definition, pyelonephritis is a complicated UTI, and that's regardless of patient characteristics. In the absence of these symptoms, then we consider patients with the UTI to have simple cystitis and can manage those patients differently. So I had made that prior slide, and then the IDSA published these guidelines on the management of complicated UTIs just yesterday. So this is hot off the press. These guidelines support using that framework that I just shared. And so I think this figure is really helpful to recognize the differences between the old classification and the new. You can see in that old classifications, this is certainly what I remember learning in medical school and in medical training, that uncomplicated UTI was really limited to cystitis and afebrile, non-pregnant, premenopausal women who didn't have diabetes and had no urologic abnormalities. So it really didn't take much to fall out of that bucket and to be classified into a complicated UTI. Like I mentioned previously, there's really been a very intentional shift towards treating patients really based off of the syndrome and kind of the level of infection, lower versus higher urinary tract. And so you can see in that new classification that an uncomplicated UTI is an infection confined to the bladder, and that's in men or women. Complicated UTI then is pyelo. It's someone who's febrile, maybe bacteremic. So while UTI is in patients with urologic abnormalities like BPH, doesn't automatically get classified as a complicated UTI, the presence of a urinary catheter does. And so you'll see there that catheter-associated UTI is under the new classification still a complicated UTI. It's not shown in this figure, but if you read the text of the guidelines, it's not just urinary catheters, that extends to stents or PCNs, so indwelling plastic. I'm going to circle back to the guidelines momentarily, but I first wanted to share a study that helps lend support to what the guidance document recommends. Several studies have demonstrated that shorter durations of 5 to 7 days perform similarly to 10 to 14 days for complicated UTI and pyelo. Most studies are in women, but there have been a few important RCTs that include men. And so I'm highlighting one of those here. This is a double-blind RCT of men treated in the outpatient setting for UTI. Patients had to be symptomatic, displaying at least one symptom of dysuria, urinary frequency, urgency, CVA tenderness, flank pain, or suprapubic pain. Cipro and trimethoprim sulfamethoxazole were chosen because at the time of the study initiation, those were the antibiotics that accounted for over 90% of UTI treatments in the VA system where the study took place. And importantly, these included patients that had prior UTIs, BPH, intermittent or indwelling catheters. This is the table adapted from that study. The top half of the table shows the primary outcome of resolution of UTI symptoms by day 14 after completion of active antibiotic treatment. There was no significant difference in this outcome between those that received 7 versus 14 days of antibiotics, and so it met the non-inferiority criteria. The lower half of the table are the secondary outcomes. It was patient reported recurrence of UTI symptoms. Difference between the short and long. Spielberg, and he's a big proponent of shorter is better. So I thought this table was just helpful, highlighting some of the more common infectious syndromes that we might see. In this reference, he's really collated references and impactful studies that support those shorter durations for some of the most common infections. And so I just wanted to share this. I think it's helpful for pyelonephritis, sure, but also for some of these other common infectious syndromes that you run into every day. One of the sources that Brad Spielberg used in that commentary to support the shorter duration for pyelonephritis is this systematic review here. It's a systematic review meta-analysis that included RCTs comparing short versus long treatment courses for acute pyelo. The primary outcome was clinical failure at the end of treatment. So in this figure, you can see that those lines cross one or actually land on the side of favoring shorter treatment courses. In the meta-analysis, clinical failure at the end of treatment did not significantly differ between the two treatment arms. There was a relative risk of 0.63. So importantly, there was no difference between the short and long treatment arms, and that held true even in the subgroup of bacteremic patients. So we'll circle back now. This is the updated treatment guidance that was just published yesterday in patients presenting with a complicated UTI. Often, if they're admitted, they're receiving IV antibiotics up front. And this figure is really helpful, I think, to think about when to de-escalate and what type of duration that you might be selecting for your patient. So they're clinically improving. They're on effective therapy confirmed with the susceptibilities you have back from your urine culture. They can then be transitioned to an active oral agent and receive 7 days of treatment. I'd say 7 days max. 5 to 7 days is usually what we say for fluoroquinolones, 7 days for non-fluoroquinolones, rather than that prior paradigm of 10 to 14 days of treatment. Even in patients with gram-negative bacteremia in the setting of a complicated UTI, this framework still applies for a treatment duration of 7 days. If the patient's not improving, then I think that really should prompt a deeper dive. Perhaps we have a drug-bug mismatch. Go back to that susceptibility profile. Have we selected the wrong agent? Is there an unresolved source? Perhaps they've developed a perionephric abscess. So we really should reevaluate our diagnosis. Or perhaps plan for a longer treatment course. We spent a lot of time talking about complicated UTI. I recognize I didn't really talk about uncomplicated UTI treatment duration. I think naturally the clinical decision-making is often more complex for complicated UTIs. There's more variable practices in treating complicated UTIs and much more recent data to support evolving best practices in that area. So that's where I kind of focused a lot of our stewardship opportunities was for complicated UTIs, but I did want to at least direct you to your local resource here that does highlight uncomplicated UTI treatment. So friendly plug, this is on the back of the antibiogram and shows the support for using a 3 to 5 day treatment course for uncomplicated UTI or cystitis. This is your most recent antibiogram. Your Urinary fecal susceptibility patterns remain pretty friendly. Still high susceptibility to ampicillin and nitrofurantoin. For the gram negatives, the most common urinary pathogens like E. coli, Club pneumo, Proteus, those also have pretty good susceptibilities. They're in that green box. Susceptibilities to cefazolin and ceftriaxone. But I did notice that there's still a pretty sizable percentage of ESBLs that you guys see for your gram negatives. So I want to take a couple minutes just to talk about that, because I think that as MDROs become more prevalent, we're starting to see more and more extended spectrum beta-lactamase producing Enterobacterales that cause UTIs. I won't spend too much time on this. I'll share the slides. As a quick background to lay a little bit of groundwork before we talk about treatment, just a quick refresher on ESBLs. Those are beta-lactamases that inactivate most penicillins, cephalosporins, and astrienam. Any gram negative can technically harbor an ESBL, but the more common organisms to do so are E. coli, Club pneumo, Club oxytoca, and Proteus mirabilis. Routine genotypic testing for ESBLs is not performed in most clinical labs, but non-susceptibility to ceftriaxone can be used as a surrogate marker for ESBL production. So this is suggested treatment for uncomplicated cystitis caused by ESBL-producing Enterobacterales. This is according to the most recent IDSA treatment guidance. Nitrofurantoin and trimethoprim sulfamethoxazole should be used preferentially. Ideally, carbapenems, Cipro, levofloxacin should be reserved unless there's other options. Those other options aren't safe or effective. We're really trying to preserve their activity for future infections for that patient. Other treatment alternatives include a single IV dose of aminoglycoside, if it's safe to do so, or in the case of uncomplicated cystitis that's caused by E. coli, oral fosfomycin is an option. Amoxiclav and doxy really aren't suggested anymore as alternative treatment options. There's just a lack of data supporting their use as effective therapy for UTIs caused by ESBL organisms. And truthfully, doxy gets pretty poor urinary excretion, so I wouldn't think of that one as in your arsenal of treating ESBL UTIs. For pyelo or complicated UTIs that are caused by ESBL organisms, trimethoprim sulfamethoxazole is still part of your preferred treatment backbone, but now you'll start to see Cipro and levofloxacin amongst that preferred regimen as well. Carbapenems do kind of now get elevated into that box, but it's really more strongly urged to reserve those when resistance or toxicities preclude the use of trimethoprim sulfamethoxazole or fluoroquinolones. If acceptable from a nephrotoxicity standpoint, aminoglycosides still are an alternative option in this case. Oral fosfomycin and nitrofurantoin are options for cystitis, but both of those get really poor penetration into the renal parenchyma, so they really shouldn't be used for treatment of pyelo. For infections outside of the urinary tract, so we're thinking maybe your patient has bacteremia coming from a urinary source, this is really where and why we reserved carbapenems. Meropenem, imipenem, and Erta are preferred. This suggestion is based off the results of the MARINA-1 trial. In that trial, patients received Piptazo relative to meropenem for the treatment of ESBL bloodstream infections and had a higher 30-day mortality rate. So that is what guides this very recommendation. In efforts to preserve carbapenems, transitioning to trimethoprim sulfamethoxazole, Cipro, or Levo can be considered once that clinical response has been achieved, like I showed in that prior flow chart. Once someone started to improve, that can really be your signal to de-escalate to an oral agent.
Dr. Gatlin?
Yeah.
There's a question in the chat that I'm going to read to you from Dr. Cabot. Your opinion on low-dose antibiotics for recurrent UTIs and the use of MCBD instead of Cipro, TMP, CMX, or cephalosporins for uncomplicated UTIs?
So you're talking about Cipro versus Bactrim?
Do you have a microphone, Dr. Caboni?
Yeah, actually, I hit enter by mistake. Go ahead and finish this ESBL, and I'll ask it later on.
Okay, all right. This is the last content slide. So the role of piptazo and cefepime for ESBL enterobacterialis is kind of a point of it depends. So I approach this question really on the clinical scenario. In the case of uncomplicated cystitis, if piptazo or cefepime were initiated as empiric therapy, and then later it's discovered that the organism isn't ESBL producing, you don't necessarily have to change or extend antibiotic therapy if the patient has otherwise had some clinical improvement. But this changes if the infection is pyelo, or certainly if it's developed into a bacteremia. If it's pyelo or complicated UTI, the panel really suggests the use of trimethoprim, sulfamethoxazole, Cipro, levofloxacin, or carbapenem. The panel that makes this guidance document does acknowledge that there's some data that suggests the risk of clinical failure with piptazo might be low in those instances, but still advises caution in using it, advises against using it for pyelo. In the case of an ESBL infection outside of the urinary tract, that bacteremia, we avoid piptazo. It all comes back to that Marino 1 trial. So what I want to highlight here is that if you have someone with cystitis, they're improving on piptazo, I don't think it necessarily needs to change or extend your treatment. So take-home points, that improving the appropriateness of diagnostic testing is important to reduce inaccurate diagnosis and unnecessary antibiotic exposure for our patients. What can we do to try to improve? Let's try to target the low-hanging fruit. Based off appropriate patient selection should really guide what tests we're doing. Try to use things like a UA pyuria screen with reflex to culture, and removing the catheters when and if we're able. Remember just that mantra from Brad Spielberg that in general, shorter courses of antibiotics are often better. And with that, I really want to thank Mary and Dr. Moore for hosting this and for helping with all the logistics. And then I want to thank others on this slide. Everyone's this is a team sport and have contributed to some of the content in this presentation. And so with that, I will gladly take any questions. Go back to the chat.
This is your chance. I know we have a lot of our infection control folks on
You
the
can
call.
see those, right, Dr. Gettler?
Yeah.
So,
opinion on low-dose antibiotics for recurrent UTIs and the use of, I think that's supposed to be macrobid, so nitrofurantoin instead of Cipro, trimethoprim, or cephalosporins for uncomplicated UTIs. So just to clarify, are you talking about kind of like using them as suppression or kind of like cycling through them?
No, I was those are two kind of questions that I was asking. You know, your opinion on the use of low-dose antibiotics for recurrent UTIs. You know, these patients that come in and they've got these recurrent infections, and they always get these recurrent infections that come back in like a week or two. As a suppressive antibiotic, I guess they don't call them suppressive anymore. They call them low-dose preventative antibiotics is what they call them now as compared to suppressive. Sometimes some people use self-start therapy, where it's a short course of therapeutic antibiotics if it's not that frequent a urinary tract infection. Kind of keeping up with this concept of shorter is better for recurring urinary tract infections. The other one is for uncomplicated UTIs. There's all this issue with a lot of people are allergic to Bactrim. A lot of people, there's all this issue about tendinitis or issues with tendinitis on the fluoroquinolones. Cephalosporins are kind of big guns.
Yeah.
And a lot of people think that macrobid, just 100 milligrams BID, 5 days, uncomplicated UTI is a pretty gentle, considered a gentler drug and a more urinary specific drug. Instead of a lot of your studies, all these studies are always looking at Cipro or trimethoprim or a big gun cephalosporin. I know that's what the VA uses preferentially, but we're not all practicing at the VA. And what do you think about just using a simple macrobid, maybe a little longer if it's a renal patient, for like instead of 5 days, maybe 7 or 10 days, just because I know they don't concentrate it in the urine as well, but you can make it a longer drug. I don't know, just your opinion on that.
Yeah. So the first question about kind of the low dose cycling through antibiotics, I certainly see a lot of these patients referred to my clinic, and I will say the number of times where we resort to using some sort of suppressive or prophylactic, whatever the terminology is, I would say are few and far between, because I think the first challenge is first, I'm assuming that the patient truly has a UTI, that other causes for dysuria, suprapubic pain, whatever their kind of presentation is, have been explored and ruled out. Then I think the kind of question is, well, gosh, why do they keep having UTIs? Do they have an underlying, renal stone? Do they have bladder reflux? Do they have incomplete bladder emptying? And kind of really investigating the causes that can predispose to recurrent UTIs. We get through all that and they're still having the symptoms. Then I have, again, depends on the patient. I have a really large cohort of patients that are kind of postmenopausal women, where it's really hard to discern some of the dysuria being from a urinary source versus related to vaginal atrophy and some other changes that happen. And so kind of having a multimodal approach to topical vaginal estrogen cream, again, having to, of course, make sure it's safe to do so with other comorbidities that they may have. I've had some success with using Hiprex, which is an antibiotic sparing agent that is really truthfully, I don't want to take too much time here for the sake of the other questions, but Hiprex can kind of be a way to try to reduce the bacterial burden in the urinary system without using a UTI, or without using an antibiotic. So an antibiotic sparing agent with pretty low risk. It hasn't been well studied in people who have advanced CKD. So there is a patient cohort of patients that wouldn't be safe candidates for Hiprex. But I've had plenty of patients where it kind of stops their vicious cycles of having recurrent UTIs. It's kind of an antiseptic. It gets the excreted into the urinary system, broken down into essentially kind of formaldehyde, and makes it really inhospitable to bacteria in the urinary system and in the bladder. And for some patients, it's really stopped that vicious cycle of recurrent UTIs. So I've found patients who love it, some who don't have success with it, but it's a pretty one of those like low-hanging fruit interventions to try. So long way of saying, I just have very few patients that ultimately get to the point of having to use chronic suppressive or prophylactic antibiotics, because we've kind of gone through the gamut of all these other things to try to stop the cycle. I don't know if that answered the first question. Let me know if it didn't. For the second, fully support using things like nitrofurantoin and reserving fluoroquinolones and trimethoprim for other indications, because I too think that it's hard to sometimes find patients where it's safe to give trimethoprim or a fluoroquinolone, or gosh, we'd sure like to save those for times when they have pyelo or bacteremia. So if we're dealing with uncomplicated UTIs, I think it's wise to think that nitrofurantoin or even some of the cephalosporins are going to be the first one or two agents you're reaching for, susceptibilities permitting. And that is a part of Danville's local guidance, is that for uncomplicated cystitis, nitrofurantoin and cephalexin are kind of your first go-tos. So I agree. I think reserving Cipro and trimethoprim for times when you have to use those.
All right, thank you.
So Patricia Dupree says that a female patient has a permanent urostomy due to bladder cancer. Is that urine unusable for dipstick test or glucose and or protein, or for pyuria due to pyelonephritis or kidney stone? Yeah, anytime there's kind of altered anatomy, I will acknowledge that the parameters of a urinalysis and urine culture become harder to interpret. And I think that's really where it's so important to rely on the symptoms. I don't know about whether the dipstick for glucose and or proteins would be unreliable, but certainly for pyuria, like you're gonna expect them to have white blood cells in there. You're gonna expect them to have bacteria in there. And so it's really going to be important to select the right patient based off of symptoms before you collect that test. Pyuria due to pyelonephritis or kidney stone. Yeah, I think if you have pyuria, it could be from either. It could be because they have pyelo, because they have a kidney stone, because they have a urostomy. That's where it's so non-specific. Patricia, did I answer your question? Let me know in the chat or unmute if I didn't. Dr. Shaw, do you recommend any intervention in purple urine in patient with chronic Foley? Purple urine. You might have to elaborate on that one for me. Cranberry helps. I have some patients that say yes. That kind of falls into that category of what I was mentioning when people kind of have this cycle of recurrent UTIs. Much like the hip racks, the antiseptic I was describing, where patients either kind of love it or hate it. I've had the same polarizing response to cranberry. Some people say, gosh, that worked for me, and others say it did nothing for me. So I couldn't tell you any science behind which patient falls into the which bucket. But again, like kind of falls into that low-hanging fruit of there's really not too many harms in trying. And so I wouldn't say that's one thing I commonly recommend in that kind of arsenal of things, but it certainly could be. I know a lot of our urogynecology partners do that. It kind of comes in this bucket of cranberry extracts, probiotics, hip recs, and in women, topical vaginal estrogen to help with like the vaginal atrophy. So it certainly could be part of your arsenal if you feel like in your experience that helps, but there's really not a whole lot of robust, strong science to support that. Let me know about the purple urine. I think I'm not getting the question. I'm sorry.
Dr.
No.
Shaw, are you on there, Manish, and can add to that?
I can.
Yeah, what-
Purple
Yes.
urine syndrome
What,
is based on the purple urine syndrome is a condition. One of the conditions can be asymptomatic bacteriuria, but and it occurs with patients who have a urinary catheter for an extended period of time, like a chronic catheter we see all the time. But it's usually colonization. It's the presence of bacteria because it causes an alkaline urine, favorable environment for pigment production. So discoloration of the urine in a collection bag. But if no other symptoms, which they usually aren't, it's not a UTI. It's just alkalinization because bacteria are present, which is alkalinization. We see it all the time with our chronic.
Okay, yeah, I don't know that I've ever heard it called purple urine, so sorry about that. But yes, I fully agree with what you're saying, and that those people are going to have, if it's a long-standing Foley, we showed that schematic about the rate in which those catheters get colonized, that if it's long-standing, it's almost 100% certain that it's going to be colonized. And it kind of goes back to not relying on the qualities of the urine, color, sediment, clarity, as indicators of a UTI.
You can acidify the urine with cranberry and it'll go away.
Could you address proper collection of urine from an ileoconduit for testing, and when should testing be done? Symptoms of a UTI with aversion. Yep, all comes down to symptoms. Ileoconduit, that wasn't sterile tissue that was placed there, and so it's going to continue to have some of those, some of its normal microbiome that comes along with it. So it's going to have white blood cells. It's going to have bacteria. I think these are some of the trickiest patients to kind of work with in terms of accurately diagnosing a UTI because of those limitations. So it really all comes down to symptoms of a UTI to guide the testing. If you're asking about specific symptoms of a UTI with diversion, you're right. I mean, the symptoms will be a little bit different than someone who has a normal bladder, but typically they'll still have some degree of kind of suprapubic pain or discomfort. Certainly if they were to develop pyelo, those symptoms would still be preserved. So still trying to rely on as many of the symptoms to be present as possible before collecting a UA from that.
I see Dr. Pradhan has popped up. You have a question, Dr. Pradhan? You're muted, Pradeep. You're still muted.
I'll put it in the chat then.
Oh, we can
There
hear you
you
now.
are.
Second. Can you hear me now?
Yep.
Okay, great. Great presentation. And 3 things I learned: Hiprex, and then cranberry, and then Pyridium. So I guess I use that. But by the same token, one thing I do is in my office, I do microscopy. Many times I used to spun the urine and do them myself, or my staff will do it. I found that much more helpful than flow cytometry. But one point you brought in is clinical presentation, and looking at the urine microscopy does help me to guide it forward. But it's very difficult to convince the patient. They do come with the symptoms. They tell me burning discomfort, but I found also atrophic vaginitis being very helpful. Elderly patient, menopause, using the local estrogen, I found that helpful. So great presentation. Antibiotic asparagus is important. Thank you for educating us. And
Thank you.
Dr. Moore, can we share the slides?
We'll
Is it
send
okay,
you a
Dr.
copy.
Gettler?
Sure. We'll send you a copy.
Thank you. One quick question. So Hiprex uses alkaline universal acid urine. Is there a restriction to that one? Can you use for everybody?
Can you use Hiprex for everybody?
Yes.
Yes. I will acknowledge it hasn't been studied in people who have really advanced CKD, and so it does have a creatinine clearance cutoff. And then if the package insert technically says they have to have acidic urine in order for it to work. Amongst kind of ID specialists, there's kind of mixed opinion whether that's true or not. My typical practice is that I still try to acidify the urine, so sometimes taking the Hiprex with vitamin C can achieve that. But otherwise, it really plays nicely with other medicines. There's not a whole lot of drug-drug interactions. So aside from advanced CKD, it can be an option for most other patients then.
Thank you very much.
Any other questions for Dr. Gettler? I just comment that one other way you get blue urine, if you look after infants, is a so-called blue diaper syndrome, which is Hartnupp's disease from malabsorption of tryptophan that gets converted to indole in the urine, and it looks the baby's diaper's blue. It's usually only something you see in newborns if you're family medicine OBGYN and you're taking care of newborns, blue diaper syndrome. But that's about the only other cause of than what we've talked about for blue urine or purplish urine.
Yeah.
Well, beets it gets close on beets sometimes in some people.
Y'all taught me stuff today, and I appreciate it.
Any final
just,
questions? Great.
Just a clinical
Dr.
thing.
Bonin,
I'm sorry. A lot of women don't like the cream for the vaginal estrogen cream, and I'm not. There's a generic Vagifem called Uvifem out there, and Vagifem is very, very expensive. Uvifem, and if they use one of those good RX cards, it's really cheap, and they can use it as a vaginal suppository, and it lowers the threshold for the women using vaginal cream because they don't like it because it's icky.
Yeah.
And so a lot of women, if you want to put them on a vaginal estrogen, you can use Uvifem, which is a generic Vagifem, and with a good RX card, it's super cheap for that.
So thanks for sharing all that.